on accommodative anomalies and convergence anomalies. So now we'll have some case scenarios by Dr. Lakshmi.
Is it seen? Yeah. So good morning and thank you, Dr. Ramya, for having me here. So I'll be dealing with clinical case scenarios in non-strabismic binocular vision anomalies. And before going into the case scenarios, I would just like to outline how we need to approach these patients. So first we have to analyze the symptoms as already mentioned. The second thing is establish with the battery of tests what problem it is and then to decide on a treatment. So symptomatology has already been discussed, so I don't want to explain further. And organic causes like diseases or any history of drugs needs to be asked, because if we miss that, that is the crux of the situation. So we need to look into that before deciding. These are most of the common antipsychotic drugs can cause a problem with near vision. So that history is very important. So points to consider while testing. Control of accommodation at each point of testing has to be ensured, and we need to use an accommodative target for testing. The second thing is neutralization of head posture. Some patients might have an abnormal head posture to fuse. So if we are not correcting the head posture, we can get errors in assessment. If there is a small vertical deviation, we need to look into the lid movement. Sometimes otherwise we'll miss the vertical deviation. Divergence test is, if performed first, will not err your convergence test. So first divergence and then convergence test. And if the patient uses glasses for close work, that should be used. And when we are using the flipper, it should be according to the age. If we use a very high flipper in an older patient, that might lead to error. And refraction, that is the base on which this is built. Binocular single vision and manifest strabismus need to be looked upon. So where do we start from when analyzing? We see a number of tests and number of results. So where do we start from? So we have two methods to approach this. One is by looking at the data alone. The other is to see the symptoms and then group them and analyze what it is. But ideally, we need to use an integrated approach where we use the tests, group them, and connect it with the symptoms and then identify the symptom. So how do we group these tests? What has been told? First is the positive fusional vergence group or PFV tests. So these are the PFV tests that has already been discussed, direct and indirect. And then the negative fusional group, that is the second group. And third is the accommodative group data. So we have three sets of data from that battery of tests. And before going into analyzing, the basic thing we need to check is when the patient wants to maintain fusion and straight eyes. When the eyes are diverging, you need to converge it. And when the eyes are converging, you need to diverge it. So that is the balance. So we are just testing that in order to ease the patient. So asthenopia, when the patient comes to you, first we have to check a cover test, find out whether the patient is having a phoria. So most often they might have an ortho for distance, and near they'll have ESO or exophoria. If it is exophoria, then we have to see the positive fusional data. If it is an esophoria, the negative fusional data. And if there is no significant phoria, go into the accommodative test. So we'll come to the first test, a 20-year-old college student with blurry vision after 15 minutes of reading. So these are the battery of tests. Now how do we approach? So first we check for phoria. He has an esophoria for near. So we check the negative fusional vergence data. So that is relatively okay. That's not very bad. And vergence facility is also okay. So now we come to the accommodative facility. He is not able to clear -2. So he is not able to induce his accommodation. And if we look at the MEM retinoscopy, it is 1.25. So he has a lag. So this is and a PRA is also less. So this is accommodative insufficiency. Though that is how we step by step approach these cases. A 12-year-old boy with similar history of blurring of vision after 5 to 10 minutes. Similarly, we see an orthophoria for distance, esophoria for near. And now we go to the NFV data. Base invergence is okay. Vergence facility is also fine. But if you look at the positive relative accommodation, he's having a very high positive relative accommodation. And accommodative facility, he fails the plus lenses. So he's not able to relax his accommodation, whereas the Vergen's values are relatively okay. And MEM retinoscopy is also showing a lead. So this is a case of accommodative excess. The third case is an 18-year-old boy with inability to read for more than 10 minutes. So here, similarly, we find esophoria, and basin vergence is slightly less. He's not able to diverge the eyes. But if we see the accommodative data, positive relative accommodation is less, but accommodative facility he is finding difficulty and to clear with -2. So this patient has a convergence excess. He is not able to diverge. The accommodative data are fine, but the indirect fusional vergence data are slightly different. And accommodative excess, this has already been told that near and distance, whether it is divergence excess or convergence insufficiency. The next case is a 15-year-old 10th standard student with similar complaints. And now let us see, he has orthophoria. The cover test shows orthophoria and esophoria for near. Now we check at the base in and base out vergence. Both are slightly less. It's not normal. And accommodative facility, he has difficulty in clearing both +2 and -2. So from the accommodative facility, we know that he's finding it difficult to relax and induce his accommodation. And from the vergence data, he's not able to converge or diverge. So this is a fusion divergence dysfunction. He's having difficulty in both these. So this is how we select what test to do further. So this is our exam going PG who complained of blurred vision and eye strain on reading. She was using a 0.5 cylinder initially, and now refraction showed -0.5 sphere additional. But dilated retinoscopy, there is no -0.5. So how do you deal? Do we give a plus lens for to relaxing the accommodation? Directly do not give, because we need to look at the data first. The optometric data shows a small exophoria, and then the vergence is relatively okay. But when we look at the positive relative accommodation and monocular and binocular accommodative facility, she is having difficulty in relaxing her accommodation. So she was having accommodative excess. And actually, these people with very small accommodative excess actually get relieved after we do a cycloplegic refraction. They become better. And then we gave her exercises to relax accommodation. The next is a 11-year-old female who presented post-COVID with continued near activity, and she was an ardent violinist. Her uncorrected vision was 660, 6.9. Autorefractor reading was -8.75, but cycloplegia showed only +1. And acceptance was +0.25, vision improving only to N618, near vision N8. So this is the timeline. The first visit, she had a very low accommodative amplitude of 6.6 and poor vision. And she had a very poor NPA, near point of accommodation. So she was having an accommodative spasm, and then she is not able to relax or stimulate or do anything with the accommodation. So she was started with atropine and bifocals and heart chart. And after 2 months, she symptomatically became better, and her vision also improved. Again, after 6 months, her atropine was stopped, and she was continued on bifocals and heart chart. And he was weaned off of bifocals by around 1.5 years of starting of the symptoms, and she continued to do the heart chart. So at the end of 2 years, we can see that the best corrected visual acuity is 6.6, and her accommodative amplitude has definitely increased, but still the positive fusional vergence is low, and the NRI is also low. So we need to build her up on exercises, otherwise she's going to go into the cycle again. So this is one patient. So the last case is a 20-year-old male with complaints of doubling while looking at near. So we need to find out whether they are having any strabismus. We need to check in all 9 cases. The values were such, and if we see, the near point of accommodation was 40, accommodative amplitude was very less, and MEM was +2.5. It was a severe accommodative insufficiency, and facility also he was finding it difficult to clear plus lens. So accommodative insufficiency, he has accommodative insufficiency. If we see the vergence also, it is less, because he has secondary vergence involvement also. So we cannot separate these in most of the cases. He improved with accommodative flippers, and the NPC also improved in some time. So, to conclude, refraction is the foundation on which the binocular status assessment is built. And unnecessarily don't give a plus lens. Never hesitate to do a cycloplegic refraction even in an adult. And rather than treating the values, we need to combine, group, and analyze it before to get a meaning. And never fail to take the history of stress, anxiety, or medication use, because that may be the key point you're missing. Thank you.
Thank you, ma'am. Thank you for those array of cases and simplifying how to diagnose an NSBVA by grouping these tests. Otherwise, these tests looks like a